Good evening, everybody, and you're most welcome to the Houston Theatre here in RCSI for the next topic in the MyHealth lecture series. So these public lectures were are part of the RCSI's commitment and vision to gradually increase our engagement with the public and to empower people with the credible knowledge to make informed decisions about their own health and well-being. I'm particularly delighted that our chairperson this evening is Dr. Ciara Kelly, who's a pioneer in broadcasting across a whole range of areas, but in particular in health-related matters. I think the fact that Ciara is a doctor herself makes this even better from the MyHealth lecture series, but also for the programme and for what you'll hear about here tonight. And we're delighted that she's agreed to chair these public lectures for you. So without further ado, I'm going to hand you over to Dr. Ciara Kelly.
Good evening. Thank you all for coming this evening to this public lecture on the evidence behind vaccines. I am delighted to be here because, to be honest, vaccines are something very close to my heart, in that I believe between vaccines and probably good sanitation and clean drinking water, that they are the biggest, I suppose, human interventions into our own health and into changing, I suppose, how healthy we are as a population. From a public health point of view, it is very hard to think of anything that has achieved more. We're going to be talking tonight about the evidence behind vaccines. We're going to be talking about, I suppose, anti-vaccine sentiment and what drives it. And we're going to be talking and taking questions from you as well on this whole area. And I am delighted to be here with such an eminent panel who will be talking to you tonight. First up, we have Professor Karina Butler, who is the chair of the National Immunisation Advisory Committee and a consultant paediatrician and a specialist in infectious diseases. And she is going to be talking in her programme this evening about the history of oppositions to vaccines. And I think many of us think opposition to vaccine, how could it exist? It's a no-brainer how beneficial vaccines are, but nonetheless, not everyone gets vaccinated, and for many different reasons. So I give you, without further ado, Professor Karina Butler.
Thank you, Ciara, and indeed, thank you very much to the organisers for the invitation to speak here today. And really, what I'm setting out to do in a way is to tell a story, and a story about vaccinations. And I think at the starting point, we have to remember that it has been said, and it is true, that with the exception of safe water, no other modality, not even antibiotics, have had such a major effect on mortality reduction and population growth. Globally, vaccines are estimated to prevent 2 to 3 million deaths every year, with the potential to avoid another 1.5 million if the uptake could be increased. And so, as Ciara said, you'd wonder, well then, why is anybody against vaccines or anti-vaccine? And I suppose we have to look back in time as the whole history evolved over time. So if we go back to the 10th century, actually, smallpox was one of the diseases that everybody knew and had a mortality of 20 to 30%. It is credited with having wiped out the Aztec and the Incas when it was introduced there. But in Europe, in the 1700s even, there were about 400,000 deaths every year. And in Ireland, we don't think of smallpox in Ireland, but before vaccination, in the 1800s, there were on the average about 500 cases a year, and that at times could be up to about 3,000. As late as 1967, globally, 2 to 3 million deaths every year. So this was the first attempt at vaccination. It was known back in time, and indeed back to, I believe, about the 10th century, that if somebody had smallpox and they survived it, well, they didn't get it again. They were immune. And it was known, it had become a practice, that if somebody became secondarily affected through being exposed to the scabs of someone with smallpox, that they would get a milder form of disease. And so in China, actually, topically enough, in the 1600s, this emperor, who was appointed emperor at the tender age of 5 years of age and assumed control of his section of the country at 21, died of smallpox. His son, Kang, survived smallpox, and Kang then introduced routinely the practice of variolation, or taking the scabs from people who had smallpox to others to protect them, because what he recognized, although it wasn't perfect, it reduced the mortality significantly. And in fact, in the Americas, the Indians recognized this, and what they would do is they'd wrap people in the blankets of people who had had smallpox because they got an attenuated infection, and they would have a greater likelihood of survival. So it was about a risk benefit. But of course, even then, there were those who were for it, and there were those who were against it. And there were those who were sensible people who were against it, who felt it was too big a risk to take. But there were those like Catherine the Great who felt that this was the way to preserve beauty, to preserve your skin, and the risk was worth it. And she had all her children variolated. And in fact, it was a Lady Montagu who brought it to the UK. But variolation was very crude. So the next step along the way was when some physicians and a farmer, Jesty, noticed that people exposed to cowpox, that's related to smallpox, didn't get the dread smallpox at the time. But it was Jenner who carried out the experiment and actually published his data, so he often gets all the credit for it. So he did an experiment we wouldn't do today, in that he took the cowpox from the cow, inoculated this young 8-year-old, and then subsequently inoculated him with smallpox, and the child didn't get smallpox. So that really is credited with being the first sort of step of immunization. But even then, there was misinformation, and there were a lot of cartoons at the time suggesting that if you did this, you'd turn into a cow or different things would happen. But it was an imperfect vaccine, and there were no controls, and it was variable in its effect because it would get weaker as it passed from person to person, and also they would try and store it on sticks and post it overseas to the Americas, and it mightn't work. And so that variability created a lot of confusion and fueled an anti-vaccine movement. Also, the vaccine was rather crude, and people were prone to getting secondary infections. And there were those who just felt vaccination is wrong. They felt that it was one of those channels, a very broad one, which nature opened to keep down the population, and that we shouldn't interfere with what was perceived as God's will. That if we used vaccination, that too many unfit children would be allowed to survive. And so there were even sort of hymns, anti-vaccine hymns at the time. And then there were the animal rights activists of that time who felt it was wrong to be using cows to develop the vaccine. So in the 1840s, there was the beginning of the 1850s, the anti-vaccine leave. And it's interesting that that was introduced after the idea of bringing mandatory vaccination, and that's always an issue. And I suppose maybe people, we don't like to be told always what to do. We like to make decisions for ourselves. And in Ireland, compulsory newborn vaccination was introduced in the 1860s. And that was really the beginning of the anti-vaccine movement. And there were riots in the streets when people were trying to enforce vaccination. And activism had potential for good. And we have to be conscious of that as well, because it drove critical analysis of the situation, and it improved the vaccines that were available. And it also was responsible for introducing regulation and control of the substances that were used in vaccines. So activism has potential for good. And of course, at that time, the diseases were very evident to people, because even if we go into the 1930s in Ireland, measles was claiming on average about 158 deaths every year. And that was predominantly in children under 5 years of age. Whooping cough, 352. Diphtheria, 386. This was taken from the census records. So the diseases were there and people recognized it, and they were afraid. Even in my own family, my uncle died of diphtheria when he was 4 in the 1920s. So the other thing that happened then was that there was a greater threat. There were the world wars, and people realized that in the early wars, more people died from infection and from vaccine-preventable infections than actually died from war injuries. And so when the Second World War came along, there was a huge impetus to drive the troops to be vaccinated. And in fact, there was a turnaround because more people died from trauma and injury than from vaccine-preventable diseases. Now, at that time in Ireland, as we move into the 1950s, polio was a major scourge, along with other infectious disease. And down on Cork Street was the fever hospital. People weren't allowed in, and in fact what they did was they posted the newspaper sheets with numbers for the patients to let them know how they were getting on. And polio in the 50s was a scourge, and in fact Cherry Orchard Hospital filled up with people on iron lungs. So these were things that were real threats, and people recognized them. And in fact, that counterbalanced with the development of better vaccines that now were standardized, were purer, and in fact, we entered sort of the golden age of vaccines. And at the time when I was going to school, we all lined up and held our arms out and got the vaccines. I don't think there was informed consent, but it happened. But it's foolish not to recognize the problems that were along the way. And there were problems. In the 1940s, there was a major outbreak of hepatitis B that contaminated yellow fever vaccine in troops. And in fairness, on the medical side, we weren't good at open disclosure, and we weren't good at telling people what was going on, and it was very much covered up. And the same in 1948, where the diphtheria vaccine wasn't adequately inactivated. There were cases of diphtheria. And so there have been problems in vaccine. And so one of the learnings along the way is that there has to be a sharing of information, open disclosure, as it were, and also surveillance systems to see when there are problems arising so that interventions can be made. But the benefits were huge, and Sam will be talking about it later. But diphtheria, we don't see cases of diphtheria anymore. We know when vaccine rates fall down that cases resurge because the bacteria are still around. But the only vaccine that has the only disease that has actually been conquered in humans is actually smallpox. Only 2 diseases have been eradicated. One, rinderpest in animals, a viral disease of cows and cloven-hooved animals, and the other is smallpox. Everything else, although you don't see it, you don't know it, diphtheria, the bacteria are there, they can resurge. What keeps it from circulating is the fact that we're vaccinated. So what happened in this era of anti-vaccination? Well, in 1974, at the time when children were receiving pertussis vaccine, there was a paper that came out from Great Ormond Street that suggested that people were recognizing some neurological conditions in children, and they wondered, could it be caused by the vaccine, because the timing seemed to coincide. It didn't get much traction, but once a program and the media was made about it, then it really gained footage, and what we found was that people became very frightened and they dropped the pertussis rate. And this was really credited with the rise of today's, if you like, anti-vaccine movement. And this person, Barbara Lowy-Fisher, who had a child who had learning disabilities, which she saw develop at the time, around the time that he got the vaccine. And she was an advocate for her child. Parents, we recognize, really only want what's best for their children, and even in delaying vaccine or putting it off, what they're trying to do is do what they believe is right for their children. And she was an instigator to develop the vaccine monitoring system to look for adverse events, which was a very good thing. And she also spurred the development of maybe what would be less reactogenic vaccines and purer vaccines. So all of that was to the good. But then it sort of caught hold, and a lot of spurious things came out as well. She was suggesting that the Hib, the Haemophilus vaccine, was linked to chronic disease. There was no evidence base for that. Claimed that it caused diabetes, absolutely no evidence base for that. And suggested that the hepatitis B vaccine was linked to SIDS or to multiple sclerosis. Again, no evidence for that. Now, all of those things, when queries were raised, there was a systematic review to look at the evidence to see if there was any problem. And the thing was that going against these vaccines had a very significant impact, because what happened was when the scare came out, the numbers that took up the vaccine fell dramatically and the cases of vaccine surged. And if we just look at the UK then, this was followed by very significant litigation, millions of dollars awarded, withdrawal of companies from working or developing vaccines. It did result in the introduction in the US of a Vaccine Compensation Act, but it also resulted in a lot of children becoming ill, over 100,000 cases, 5,000 hospitalized, and a number of deaths. And in fact, this figure of 36 is considered to be at the most conservative end of the spectrum. Subsequently, it's been found that you know, at that time, she was concerned because it seemed that the neurological disease developed at the time that the child had received the vaccine. But for example, in Denmark, when they were concerned, they shifted the timing of onset of the vaccines, but the timing of onset of the diseases associated didn't shift, which showed that it was more a temporal rather than a causal association. And in fact, since that time, on those children, it has been recognized that there was a different neurological condition that we now have genetic testing for that showed that that was the cause of the neurologic insults rather than the vaccine. All of you are familiar probably with the story of Wakefield, and initially the thought that could this be linked to autism, and everybody would be very keen to find out if there was any connection. Certainly it was fueled by the media, but in fact, when it was examined and looked at, recognised that that association was totally discredited, but it had a cost. In Ireland in 2000, we had 1,600 cases of measles and there were 3 deaths because our vaccine rates had fallen to between 70 and 80%. And you're aware of the story, it was retracted, and what we learned was that in fact that study had been funded by people who had certainly conflict of interest. 5 of the 8 children already had ongoing litigation. The funding was from the lawyers in part who contributed to it, and Wakefield was subsequently struck off. He moved to the US and has served as an advisor to President Trump on vaccination policy. And it became a popular movement as well, and a number of celebrities joined the ranks. And here we can see an example of how misinformation can enter the debate. Heather Whitestone was a Miss America and came to fame because she was one of the first deaf Miss America, and her mother claimed that her deafness was due to the DPT vaccine. In fact, it was subsequently revealed it was due to a vaccine-preventable disease, namely Haemophilus influenza meningitis. Charlie Sheen, a medical authority of note. Jenny McCarthy, a woman whose child unfortunately has autism, and that is very difficult, looking for a cause, but felt that it was due to the MMR vaccine and joined by Jim Carrey in that, and then others who have joined that bandwagon. Unfortunately, with social media, the influence that people in these positions have is really quite remarkable. And in terms of Donald Trump, he actually was a noted anti-vaccinist as well, but as we can see, sometimes things change. We'll have a look and see. But here's kind of the impact, and if I can trace down, this is the fall off in terms of the MMR vaccine. But you can see how long it has taken to restore confidence. And even to this date, I will have people who are genuinely convinced that there is a link between MMR and autism, even though it has been studied in numerous studies and there is absolutely no evidence for that. More recently, in terms of measles, we've seen the recurrence of outbreaks of measles throughout Europe, and here we see the waves of measles happening. And this is not innocuous, because 1 in 500 to 1 in 1,500 with measles will die. We have yet to see the full fallout from this, because with measles, even for those who get over it, there is a risk of developing a later progressive neurological disease, subacute sclerosing panencephalitis, which can happen. And I'm sure we may yet see that. But in these outbreaks, we can see these are clusters of people who didn't use the vaccine, and 55,000 cases, 49 deaths. And it's usually the young children that are most affected. The same here, 480 children infected, 5 deaths. So measles is a real threat to people's health. Coming on to HPV, which is probably one that's been most topically in the news. In Ireland, every year, 300,000 cases of cervical cancer, 90 deaths, and other cancers, and you'll hear more of that later. Initially, the vaccine was going to be introduced. Then there was a stop because of the recession, and the newspapers were clamoring as to why we haven't got it, get it. Then it was introduced, and uptake rates soared, and we had very good uptake. And then Chinese whispers. In Japan, there was concern that this was related to causing chronic fatigue syndrome and other symptoms in girls. That followed to Denmark, that followed to Ireland. There was a domino effect. In the absence of evidence, there was a concern, but no evidence. And what happened? Vaccine uptake rates fell. So what were the concerns? Well, parents were concerned. They were concerned for safety. That is reasonable. They were concerned that this might have serious side effects. They felt they hadn't got enough information and that the consent process was too rushed. And there was learning in that because recognized maybe it was too rushed. They needed more time, more information. But there was also an underlying distrust in the healthcare system and a certain anti-establishment agenda. But the concerns were raised, so what should be done? And these were the concerns, that an array of different symptoms might develop due to it. Well, when concerns are raised, you have to pause and stop, and you have to go and look at the evidence and see. So in 2015, there was an EMA review that looked to see what the incidence of these chronic regional pain syndrome and postural orthostatic tachycardia syndrome were in Europe, and they looked and they found there is a very significant incidence of these. These are real entities. Children, young people do get affected by them, and they do interfere with health and well-being, and it is not trivial. But the incidence was the same in those who were vaccinated as in those who were unvaccinated. And as a paediatrician, I can say this is something I saw before there was ever HPV vaccine. I saw it in boys who were not getting HPV vaccine at the time, and I saw it in girls who did get and girls who didn't get it. So that was it. This is one of the most studied vaccines throughout the world, but again, there was a lot of fueling of anxiety, accelerated through social media and the media, and also people coming out with statements in the absence of really being themselves informed, and therefore leaders that we expect to know better coming out with statements, which is going to obviously undermine confidence in the program. But I can tell you that there, and you will hear more about this, that this vaccine, it is probably the most studied vaccine in the world, and there has been really no evidence of any serious safety concerns with it. The Global Advisory Committee on Vaccine Safety, an independent expert clinical and scientific advisory body, and you have to be totally independent of pharma or anything like that to be on this, looked at it, over 270 million doses distributed. And the real world benefits are there. I won't delay on this, but we are seeing reductions in precancers, and now, because time has elapsed, reductions in cancers. It is a huge benefit. And for those who argue natural disease is better, I've only one answer to that, and all of you may know just this time a year ago, we lost a very good friend and advocate, Laura Brennan, who highlighted her pathway through cervical cancer and highlighted the fact that she had not had the opportunity to have the benefit of prevention of this disease. And she died a year ago. So natural disease is not better. Nor was it better for this man, Jacob. This was taken, I happened to be in another country at the time, in Australia, and this was on the newspaper. A young man, a young father of children, who on Christmas Eve became unwell and had meningococcal disease, a vaccine-preventable disease, meningococcal C disease, and as you can see, lost 3 limbs. Survived, but he would not believe natural infection is better. Or measles, and I've talked about that. Measles, if a child is left blind, if a child is left later, or if a parent has to watch a child slowly deteriorate with subacute sclerosing panencephalitis. Or the children with polio. Polio was almost eradicated. And then with war and with troop migrations and problems, the vaccine programs were interrupted, and the numbers of cases resurged. And Laura. So natural infection is not better, and those who survive the serious disease would not believe it so. But there is hope for change. The bishop had to change his controversial remarks. He misunderstood what 70% protection meant. He thought it was only 70% safe. And Finney McGrath says it all. And even Trump has come out now recognizing the impact of measles on the economy as well as everything else. And so there's hope for change. But there are challenges ahead. No medicine, no vaccine is 100% safe for 100% of the population. but neither is getting in your car to come here today or crossing the road. You have to look at the balance of risk, and the risk from the diseases much, much greater than the risk from the vaccines, which are minuscule by comparison. But on the other side of the equation, there has been a lot of learning, open, honest, transparent communication, and that is really important. And absolutely the medical profession has fallen down on that, and we are learning all of the time. We have to improve how we communicate risks and how we communicate benefits. We do need to be active to look for adverse events, and when they occur, to react to them and not to deny the possibility that they can happen. And we have to provide support for those who are adversely affected, and that is a work in progress. But vaccination is important because vaccination saves lives. Vaccines are safe and protective. They protect you and they protect others, and they save time and money and the economy, and they protect our future generations. Thank you.
Thank you very much there to Professor Karina Butler, and particularly lovely tribute to the late, great Laura Brennan. Up next, we have Professor Sam McConkey. Sam is an Associate Professor and Head of the Department of International Health and Tropical Medicine at the Royal College of Surgeons in Ireland, and is also a consultant in general medicine. And he is now going to be speaking about the evidence behind vaccinations. Thank you.
Thanks, Kira, and thanks to Steve for inviting me to speak at this. I was obviously thinking about how to go about this. The true me, as some of you know me, realise is probably the sort of complete mathematical nerd that loves figures, numbers, graphs and tables. I was one of those people that said I should be an actuary at secondary school, and I obviously went into medicine. So I was told that I shouldn't do that, and I should tell you 3 stories. So I'm going to tell you three more or less stories of my own background, which is very, very diverse in medicine and healthcare. I'm shocked, of course, to find that it's 31 years ago that I qualified, so I've had lots of sort of experience. The 3 stories really that I hope I can share with you, there are a few graphs and numbers. I couldn't leave them out completely, but I'll try and give them a story. Well, the first one is building on what Karina mentioned about meningitis. And I'll tell you a bit about, try and share with you what it was like in the early 90s, 1991, 92, for those of us who are looking after children with bacterial meningitis in Dublin then. The second example is neonatal tetanus. That's, I probably should warn you, there will be distressing photographs on the slides. Neonatal tetanus, one of the most horrible things that I've seen a lot of. And then the third is I spent 5 years of my life in Gambia doing work funded by the Wellcome Trust on vaccines for hepatitis B with the agenda of curing cancer. So not just is it human papillomavirus and cervical cancer and oropharyngeal cancers that be controlled by vaccination, hepatitis B causes liver cancers, and it's the biggest cause of death in men in Africa and Asia. So I'm going to share those. I have spent lots of my life developing vaccines, and we've done first-in-human studies in Ireland. I've also done lots of phase 2, phase 3 studies in Gambia and also in UK and US. So I'm going to just hint a little bit about the development process, which is a fairly highly regulated, highly organised, open, transparent process at this stage. And as I said, we in RCSI and Beaumont have actually been doing phase 1 studies of first-in-humans for vaccines here in the past. So the three different bacteria cause most of bacterial meningitis. And this is sort of the horror of horror stories. I remember writing a little narrative in secondary school. It was sort of a cowboy story, and I needed a tragic twist, and the poor child got meningitis and died. At that stage, I didn't know what meningitis was. I just knew it was an absolutely awful thing. And the 3 things, of course, are Haemophilus influenza B, which Karina has mentioned, Streptococcus pneumoniae, which is, sorry, spelled wrong up there. Oh, apologies to my mentors and teachers. And Neisseria meningitidis. There's A, B, and C, but C was the biggest one. So this is a picture of Our Lady's Hospital Sick Children in Crumlin, where I worked with, I will say, Karina as my mentor and teacher for quite a bit of the time there, also with others. So I was there as a junior doctor, known as a senior house officer and later a registrar. they're sort of the grade above intern who are really on the front line and see everyone and to some extent do all the practical work. But I will reassure you, under supervision of wise other people who help and guide you. So it's not unsupervised, it's doing all the frontline work, but in a supervised way. And Karina, in fact, was my supervisor at that stage. So this was 91 and 92 in the emergency room there, where at night, as the SHO, I was the main frontline doctor. And lots of children and babies coming in with fevers, which just children get lots of. The easy ones sort of have a rash. That's what everyone knows about. But there's the other sort of whiny ones that are just distressed and you're not quite sure what's wrong with them. And my mentors taught me that if you're considering meningitis, that's probably the time you should be doing the lumbar puncture. Once you're considering it, do it. So I probably was, that's my approach, just be thorough and do the test. So I did a lot of lumbar, typically 2 or 3 a night. One night we did 7 lumbar punctures on it. Sounds pretty awful, but in fact, it's once you're good at it, it's in and out. It's like having a blood test. So it's not as invasive or certainly not as dangerous as lots of people imagine. So it's an accurate and fast and rapid diagnostic test for bacterial meningitis. Of those 7 that I did in one night, 2 turned out to have meningitis. So that we weren't just wasting our time here. We were actually looking after children. And then the Evening Herald got wind of the story because one of them died. And they said, there's an outbreak of meningitis. And a wonderful doctor, public health, Dr. O'Hurl, he said, no, it's not an outbreak. And then there was another case, and another case, and another case. And eventually the Evening Herald said, this must be an outbreak. And eventually Dr. Hurley said, yes, there's a problem here. We've got an outbreak of meningitis in Dublin. And we'd lots of dozens of cases and several deaths. Even with good care and intensive care, there's a lot of morbidity of brain damage, deafness, and you saw the limbs earlier, and shock and multi-organ failure. We still see this now in our hospitals, but typically now it's E. coli, staph and strep. So I'm still an adult infectious disease doctor looking after folk with septic shock and multi-organ failure, but they're different pathogens. We're not seeing this level of pediatric meningitis. This is really the horrible photograph. So in an intensive care, tubes in helping this child breathe, typically inotropes, meaning adrenaline, noradrenaline to keep the blood pressure up, and yet still there's these blotchy purple rashes indicating coagulation failure and bleeding and capillary dysfunction. So there's this thing called a SOFA score, which is a score that measures the 6 body organs that you need to stay alive. They are your heart. If that stops, you're gone. Your lungs, you need it. Your kidneys, your liver, your coagulation, and your brain. And those are the 6. You can do without guts for a while, but those 6 you need. And a lot of these kids with bloodstream infection, Neisseria or E. coli, get rising SOFA scores. It turns out in adult medicine, once you have 5 of those gone, you just have to accept that there's almost nothing you can do to make that person better. Once you have 4 of those gone, about 50-50 get better. Once it's 1, we've very good support for single organ failure. Somebody who only has respiratory failure, we can keep them alive until they recover. I'm just shifting into my coronavirus 19 talk there, because they all get single organ failure, you'll be happy to hear. So if you have a good anaesthetist, I've booked my anaesthetist already, and he will hopefully ventilate me at that stage, but I apologise for that. I was trying to avoid that, but I failed completely. Anyway, we'll keep going. So what happened? So this is numbers, and this is not from faraway places, this is Irish numbers. The Health Protection Surveillance Centre are doing a great job. And you see where we're getting every quarter 30 to 50 cases of Menxi each quarter. And then we have a vaccine and it essentially disappears just to 1 or 2 cases. So this was a tremendous success. It worked for Menxi in the UK as well. It also worked for Haemophilus influenza subtype B a few years earlier. And it also subsequently worked for pneumococcus. This is invasive pneumococcal disease, which again is the data from the US. So just we're in Ireland. I'll share with you that about 12 miles from here in Grange Castle, most of this product is manufactured for the world. So we're exporting, the biggest selling vaccine in the world is manufactured about 12 miles from here by Pfizer in Grange Castle. So it's an export product. And people wonder, what are we doing in Ireland? We're exporting loads of Prevnar as it is. So, and that's been a very successful product. So successful at times that it's hard for them to make enough. It's been in huge demand. The route to these vaccinations is quite interesting. Again, just for a bit of technical stuff, it's the surface of these bacteria. It's the surface polysaccharide that's one of the best immunogens. The polysaccharide means carbohydrates, sugars if you like, chains of sugar molecules that are on the outside coat of these bacteria. If you give them to adults, you get a good immune response. Children under 2 don't mount a good response to those polysaccharides. So the technology evolved that if you stick them together with a covalent chemical bond to an immunostimulatory protein like tetanus toxoid, then you get a much better immune response. And that worked for Hib very well. These were tested and licensed, marketed, and worked for Hib and strep pneumonia. Then David Salisbury, who's a friend of mine, was the vaccine leader in the UK in the late 80s, early 90s, and felt if this technology is working for Hib and for pneumococcus, please could we have a vaccine for meningitis? And he was the government leader and government spokesperson for vaccines in the United Kingdom. So he proposed a demand approach and put it up to the companies and said, if someone can develop and manufacture a successful, say, vaccine for meningitis C, I will guarantee a good price. It was something like £50 a dose for it, for all the kiddies in the UK for 10 years. So he put up a cherry, if you like, and created that demand. And the same technology that worked for the Hib and pneumococcus then worked for Menxi. And we now have a Menxi vaccine that, again, has worked really well. So I just thought to give credit to Pfizer. This is Grange Castle, since we're here only a few miles away. So I think it's a beautiful picture. It makes Ireland look wonderfully green and sunny, which unfortunately it hasn't been for the last month. It's probably in a bit of rain now, but that's something that we in Ireland have been really good at. This is where I grew up in Monaghan. It's a graveyard called Killeven. The church there was founded by St. Patrick's blacksmith by legend, and there are several stories of St. Patrick falling on his horse and leaving the tracks of his horse's knees in the stones in the little river. And these are the bluebells beside where my mother lives. So I'm coming from a rural, traditional country area where people have their own fables and stories. And myself and Mary, my wife, we decided we'd go and explore other places and worked for several years in Sierra Leone. We worked for the Holy Rosary Sisters, a group of nuns from Kilishandra who set up a mission hospital there in the 40s. And they were all sort of dying out, so we went and worked there for a couple of years. And one of the first time I worked in Sierra Leone, one of the really shocking diseases that I vaguely heard about but never seen before was called neonatal tetanus. And the story works like this. Mothers are in, they have their baby goes home. 3 to 5 days after delivery, the mother brings the baby back to the hospital with the baby's not suckling. The baby isn't able to suckle, doesn't have the strength, doesn't have the power to suck the breast, which essentially is a death sentence in Sierra Leone. And when you examine the babies, their tone is increased. The masseter muscle, the jaw muscle, is really tense. They're sort of cringing in the face. The arms are tense, the elbows are flexed, the legs are flexed, and I'm going to show you a picture of this. It's balanced with a good picture of what kids grow up to do, not just in Sierra Leone. In my youth, I spent my life riding around in cows and bulls in Monaghan as well, so this is also the entertainment for farmers in Monaghan, but that particular one obviously is a Guinea-Bissau picture. Just to balance that there is happiness in the world. Karina's telling me I'm a pessimist, and she may be right, but there's also an optimist in there as well. So there's happy bits to life, but this is truly one of the horriblest things that I've seen. And if we were in a high-tech environment, we could potentially intubate and ventilate, and we could keep the babies alive, we could feed them nasogastrically, and we could sedate them, and sometimes with maybe several months of that therapy, they might get better. We didn't have any of that technology in Sierra Leone at that time. And the vaccination program wasn't up and running. So what happened? From that time when I was in Sierra Leone seeing the neonatal tetanus, I was back training and doing my paediatrics and various things. And in that interval, the antenatal clinics in Sierra Leone started vaccinating all the mothers antenatally for tetanus. So this is vaccinating a mother. So the mother generates a protective antibody, and some of the antibodies, IgG, crosses the placenta, and babies are actually protected by their mother's immune system. So in the first few weeks and months of life, our babies are protected by the immune system of their mothers, and that's really important and really fantastic that works. So by a national vaccination program with tetanus vaccine for mothers, this disease actually became a non-entity in Sierra Leone. When I was back then, I worked for a couple of years, 93 and 94 again, in Sierra Leone, and again, no cases of neonatal tetanus at that stage. This is the data from 2 studies, which I didn't do this data, but it's again showing a dramatic decrease in the rate of neonatal tetanus in vaccinated mothers. So this is a disease that even in resource-poor countries with not great perinatal hygiene, we're actually seeing has disappeared due to tetanus vaccination, which is great. So my third story is I spent 5 years working in the British MRC laboratories in Gambia, which is another small West African country, about 1,000 or so miles north of Sierra Leone. And this was quite luxurious, actually. I worked beautiful beside the beach and nice house and a bit of 24-hour electricity, as opposed to Sierra Leone, which was really in remote rural environment. And there, the Wellcome Trust gave me a lot of money to study liver cancer and hepatitis B-induced liver cancer and treatments for this. So the reason for this is because in West Africa and Sub-Saharan Africa generally and Asia, the most common cause of death in men of cancer death is liver cancer. And the main driver for that is hepatitis B. It's not particularly common in Ireland in the past. It's increasingly a lot now, but it wasn't a big issue in Ireland, so I hadn't seen it before that being there. This is a CT scan. I don't know, we can maybe orientate for interested in medicine. So this is sort of the vertebral body of one of the thoracic vertebrae. These are the ribs. It's a cross-section through the thorax. For all of these cases, you're looking from below up. So this is the liver, that's the spleen, this is the stomach. This large white thing shouldn't be there. It's a white blob because there's intravenous contrast. There's sort of like a dye has been put into the bloodstream, and that highlights the blood vessels. This big white thing is the aorta, that should be there. This white thing isn't a blood vessel, it's actually the bone, it's the vertebral body. This is where the spinal cord is, the pedicles, posterior spinous process, and lateral processes of the vertebrae. So this is a normal-ish liver, and this is a big vascular lump, which, when you see that, it's almost certainly a hepatocellular carcinoma. You don't really need to biopsy it. Very good serum marker, it's called alpha-fetoprotein. Do the blood test, which we had, and that's unfortunately definitive confirmation of hepatocellular carcinoma. And once they get over about 3 to 5 centimeters, it's really difficult to treat. If you get a tiny one, you can surgically resect it, and there are various different injections of alcohol and processes that can treat the small ones. Once it's big or once it's metastasized, the outcomes are very poor. So it was known in the Mende language in Gambia as a male pregnancy. Old men of 70 and 80 or 60 or 70 would develop a swelling abdomen. In medicine, we call that ascites, or fluid in the tummy. Then they would get craggy, knobbly lumps on their liver. Then they would get very thin, and then in a few weeks' time, they would die. And the community knew that if a man developed this male pregnancy, that was a prophecy of doom. They had no chance of survival. So it was so common that everyone sort of knew about this. What happened then? So in about 1988, we had very good hepatitis B vaccine, and we developed a national program in Gambia for hepatitis B vaccination. And within 5-8 years after that, we were able to show reductions in hepatocellular carcinoma. This data is actually from Asia, where it was also done on a very widespread scale. I worked on this hepatitis B national program, and we published a fair bit about how long do the antibodies last, and we showed that after 15 years you still have got good protection after neonatal vaccination. I'm delighted to say in Ireland we're now vaccinating all our babies for this. So this is showing rates of decrease of acute hepatitis and hepatocellular carcinoma in adolescents and young people after and before the vaccination program. How am I doing? Am I doing okay on time? Is my time? I'm okay. Okay. So I've spent a lot of time and thought trying to develop new vaccines, often industry-led or sometimes industry-led, but also often academic-led, where university academics develop their ideas, and that's how many good ideas start. They start in university incubators of ideas. The current Ebola vaccine, for example, started in the Public Health Agency in Canada. So it wasn't private sector who started. It was a public agency come up with this vesicular stomatitis virus. They took a relatively benign virus, took out one gene and put in an Ebola gene, the surface polysaccharide type or glycoprotein gene of Zaire strain of Ebola, and tried it out in preclinical trials in animals. It worked. Tried it out in clinical trials, and then you need a big pharma to make it. They got Merck involved. Merck are now licensing it, manufacturing it, and distributing. So we now have a reasonably good vaccine against Ebola. I have 5 slides on coronavirus because I couldn't stop it. So in Oxford, we used to challenge people with malaria. To test malaria vaccines, we used to give people malaria, Plasmodium falciparum, to see if our vaccines worked. And the most famous challenge experiments were done by this man. His name is David Tyrrell. He led the common cold unit in Salisbury in Wiltshire in the UK for many, many years. And, you know, the joke was that he never found a cure for the common cold despite about 40 years of trying. But he did discover coronavirus because about 15% of the regular common cold is due to coronaviruses that we know of. So they're not just as new as we think. And he showed that if you take the sort of snot that we all produce from our nose and inoculate it into somebody else, then that causes them to get coronavirus infection as well. Now, I wouldn't recommend this experiment at all. We should be doing the opposite. That's essentially what he did. And the OC in the first strain, Hpv OC, is organ culture. So he was growing it in human organs. He couldn't culture the thing. And then we've had several more coming after that, and MERS and SARS. It's more common in winter and spring, so some of us are hoping it might go away in the summer, and it comes back, sadly, in epidemics every few years. So you don't get normal immunity. It's a big virus, big RNA virus, and many of the things like Rabvarin doesn't work. So the context is Wuhan, 11 million people, they've just gone mad there with the health systems being completely overwhelmed by it. We've learned that isolation on a cruise ship doesn't work. We've learned that whatever they're doing in northern Italy doesn't work, and it's not clear whether what's happening in Japan or Korea is working yet. So the question now is, can we replicate the social distancing and the contact tracing that happened in China to be able to control it like they have? And I'm not sure that we can. You get pneumonitis, single organ failure in about 95%. So you need a bit of oxygen. Sorry, I'll bring that 95% back. That was an error. I should start again. So for 80% of people actually get a very mild disease like the common cold. Of those who get very sick, it's single organ failure. It's not multi-organ failure. So with a bit of oxygen, and ECMO is the thing. Unfortunately, there's only 2 ECMO machines. Should I translate what ECMO is from the audience? I should. Extracorporeal membrane oxygenation. That's the best high-tech machine we have now to support broken lungs. And as I said, there are 2 or 3 of them in the matter. It's essentially a heart-lung bypass machine. And it, big black box, you take your blood out, oxygenates it, and it pumps it back in again. So it's like a dialysis machine that works for the kidneys. This is a big machine, works for the lungs. So that's been used in that area. So we're seeing mainly older people in China getting it, and mainly in Wuhan. I'm going to end with a happy photograph. This is, again, the boats in Gambia. So thank you all.
Thank you for that, Sam. Next up, we have Professor James Paul O'Neill, who is a graduate of the Royal College of Surgeons in Ireland and has won both the RCSI Council Medal and the Dr. Jim Mahon Medal for Medicine. He is a consultant, and I've tried this earlier, but I'm going to say an ENT because otolaryngology, as you know, is a very hard thing to say. But he's going to speak now on the HPV vaccination, facts, fiction, friction.
So good evening, ladies and gentlemen. Welcome to the Royal College of Surgeons in Ireland. Thank you very much for the invitation to talk this evening. So this is a patient of mine who noticed that there was a problem on the tonsil, but rather than seek medical attention, decided to take a really good selfie. Let's forward over a year later. The problem is growing, but decided just to take another selfie. So let's continue on again. We're now up to the winter. Let's go on to the next year. And then finally, in 2015, in the summer, had referred pain to the ear, and that medical students in the audience will know through the glossopharyngeal nerve, and that resulted in seeking medical attention. That patient is now cured of their disease. If that was garden variety head and neck cancer, you'd be long since dead. But it's not. This is a HPV cancer. So every mutation you see here, this is HPV negative, so this is a chemical carcinogenic driven process, smoking, drinking, as opposed to HPV positive, which is a viral driven process. So every color you see here is a mutation. The more mutations a cancer has, the smarter the cancer. And what you can see is relatively few mutations here. So if you like, it's a dumber cancer, and a lot of the time it'll respond to a cytotoxic agent, and the patient will do well. Next case. So this is a patient that has this is a PET scan. So you give someone radioactive glucose. Anything that's replicating at a higher rate takes up the glucose and shines. So it's an anatomical and a physiological study. The brain always shines, but this shouldn't be shining. So this is a tumor that's within the oropharynx. The oropharynx. So when you look in your teeth tonight and you're brushing your teeth and you go, ah, you're not looking in your mouth. You're looking at the oropharynx. So it's soft palate, tonsils, base of tongue. That's the oropharyngeal region. And this is an oropharyngeal tumor which is extended into the oral cavity. Now you're thinking to yourself, so how would you treat this? Well, your man's a surgeon, so he obviously just wants to operate. But it's not really as simple as that. The first thing we need to do is we need to stage the patient. So we do what's called the TNM classification, the tumor, the nodes, the metastases, to work out how advanced their disease process is. And we do maybe additional imaging, et cetera, in order to find out exactly what stage that patient is at. The staging process was put together by this man here, who is probably the world #1 radiation oncologist in the world, Brian O'Sullivan, and he's a dub. Great man for a pint of Guinness, and is Professor of Radiation Oncology in Toronto. We would also look at, for example, so say someone does have nodes, what is the implication of having nodal disease? What does that mean for the patient? The number of nodes, if there's what's called extranodal extension. In other words, here's the surface of the node, but this is cancer going through the node. What are the implications of that for the patient? We'd also look at mutational status of their disease. And then from that, we would consider risk. So let's say all of us in this room have cancer. Well, we have to divide up into low, medium, and high risk. So risk is a term we use a lot in head and neck disease. So then, these images are real, but they're difficult to see. What are the options? Well, yeah, one maybe is surgery. So what I'm doing here is I'm rotating the base of the tongue out for you to see. This is following resection of a large oropharyngeal HPV positive tumor. Okay, you can see this is the uvula of the soft palate here. There's the upper jaw there. There is the epiglottis. You can see this is the endotracheal tubes. That's a nasotracheal intubation. You can see we have a large resection there. So as horrifying as you may think it is, you're looking at healthy tissue. That's following resection of a cancer. However, maybe we don't need to do an open procedure. Maybe we could do transoral laser microsurgery, which I was doing earlier on today. So that's another option. Or maybe we could do robotic surgery. Or maybe we don't operate at all. But often with neck disease, we will need to remove those neck nodes. So this is what we call a neck dissection, an operation I did this morning, where we remove involved lymph nodes within the neck and essentially fillet the neck of cervical lymph nodes and removing that pathway of disease, or indeed removing cancer itself, until you have all the right structures but in place, but the lymph nodes have been removed. If we don't operate, we could do radiation treatment, or we could do chemotherapy, or we could do a combination of the two. So how do we know which one to do? Well, now we look to, with all that evidence, we look to the literature. We look for guidelines in terms of what's the best way to treat according to the stage. So it's evidence that we base our decision-making on. So the cancer team, I'm part of my cancer team. There's a huge cancer team. And we meet at our multidisciplinary meetings where, according to evidence-based medicine, we make our decisions. In this case, the patient did not have surgery, had chemotherapy and radiation treatment, what's called concomitant treatment. In other words, they were given together, and the tumor, fortunately, responded. This is another patient who also had a HPV positive disease. This is a lymph node that is pathologically involved. You can see here, there's the carotid here. This is with contrast. So there's a CT scan. So how do I know it's with contrast? Because the vessels are shining. So they have contrast within them. So here we've got our carotid system here, and we've got our jugular, and you can see the jugular here is compressed, and we have a metastatic deposit here. Now, it's HPV, so it should do well, right? Well, unfortunately, that didn't happen in this case. So here we are 18 months later, and now what do we have? We've got lung metastases, multiple lung metastases. It gets worse. This is a sagittal image, an MRI scan. We have bone metastases as well. So this patient will die of their disease, and they're now on targeted treatment. And that's the reality of it. Up to 20% of people with HPV disease will develop distant disease. There are bad actors amongst a good cancer, quote unquote. So in relation to HPV, cervical cancer remains the second most common cause of death from cancer in women worldwide. But oropharyngeal head and neck disease has actually surpassed cervical cancer in the United States of America. So we're going to hear more and more about this disease process. We know there's over 200 types. We know 70 million Americans are affected, about 14 a year. And essentially everyone in this room has been exposed to HPV, like it or not. The main player from an oncological perspective is this guy. It's type 16. That causes the dominant problems both in the anogenital region and up in the head and neck as well. But you can see even the common wart that we all had as kids on your finger, that's types 1 and 2. So there's your common wart. There's genital warts, which is type 6 and 11. It's extremely common. Here's cervical cancer, predominantly 16, 18. Anal cancer, predominantly 16. Here's respiratory papillomatosis. So this is benign type 6, type 11 infection on the cords. So this is the vibratory fold of the vocal cords. Clearly that patient is going to be dysphonic or hoarse. And that can be very severe. This is a patient this morning, and you can see the whole anatomy looks altered, and that's because of all this population of papillomatous disease. So here we are this morning, and we're doing laser surgery here.
Just leave it on a little bit longer there, Robbie.
So this is the laser here. You can see you can see the burning on the surface. This is a CO2 laser that we use at a very low wattage, okay, and we defocus the beam, so we just literally burn off these superficial areas of disease. In terms of how many people are affected by this, thousands of people, male and female, are affected by HPV disease every single year. 130, now this is very conservative, this is back in 2010, 2014, deaths per year. So this is a real problem. What's happening in terms of cancer? If you're going to get cancer, what happens predominantly is you get a dysplastic process. What does that mean? Within your tissues, you have a layering of cells. If there's an altered layering, that's called a dysplastic process. You can have mild, moderate, and severe. And in this case here, we have a dysplastic process until we have in situ cancer, which is severe dysplasia. But cancer is invasion. Once this basement membrane is breached, now we have an invasive process. That's an invasive cancer. In terms of head and neck disease, so when we were in discussions with HICWA in particular about including boys on the vaccination program, we did an audit looking at 2009, 2013, 2014, 2018 in terms of what's happening with oropharyngeal disease in this country. What did we find? There was a 37% rise in oropharyngeal cancer in Ireland. That's massive, ladies and gentlemen. That's an enormous rise in cancer. Of those, 50% were HPV related, and of those HPV related, nearly 80% were men. So this is, again, when you're trying to prove a point, it has to be through evidence. And this, what we were showing here is that the head and neck, from the head and neck perspective, this is predominantly a male disease, which is what we see in other countries as well, as opposed to the anogenital region, which is predominantly a female disease. The transistor radio. There was this kid, and he could put together the transistor radio faster than anyone else in the factory in a rural area of China. So much so that his factory workers said, you know what, you need to go back to school. So they funded him going back to school and eventually got into medical school. And when he finished medical school, they contacted Cambridge and said, we've got a very bright young man. He wants to do a PhD and he's interested in virology. Will you accept him? And Cambridge said, yes, we will. So this young man you can see goofing around in the laboratory, this is Yan Zhu, who ultimately died of hepatocellular carcinoma because he wasn't vaccinated. And himself and this other man met each other in Cambridge at that time. So Yan Zhu arrived with not a word of English, and Ian Fraser was telling me that coming from working class Glasgow, he arrived in Cambridge, and he didn't have much English either. And together they put together the HPV vaccine. What is it? Essentially what it is, what you're looking at, are HPV virus-like particles. In other words, it's an empty protein shell. Okay, it looks like the HPV virus. Morphologically similar to authentic HPV virons, but contains no viral DNA, no live biological material, hence cannot multiply and are not infectious. Now, in terms of vaccination, anti-vaccination, there's this been dangerous and counterproductive war. It hasn't helped either side. Okay, and in particular, a lot of mud throwing on both sides. And one of the functions of tonight, whether you are pro or anti-vaccination, it's great that you're here. And whether you leave pro or anti-vaccination, that's fine. But at least we can talk about it. And that's really important that we do this. There's probably a very mixed audience here this evening with healthcare workers to entrepreneurs to parents to et cetera, et cetera. Many people in the anti-vaccination groups are those that feel ignored, they feel maybe even victimized by mainstream science and media. And like any responsible parent, they're trying to protect their children from what they see as a grave danger to their health. So this little girl here, as you can see, is about to win the Most Gorgeous Little Girl Award. That's my little girl there. And she, in particular, if any parents are here whose children have disabilities or special needs, or they attribute the vaccine to be related to that, you're very welcome. My little girl has complex special needs, and we don't know why. I understand the difficulties and the intense frustrations into trying to find out why. But what I can tell you from the evidence is that this vaccine is safe, this vaccine is effective, the vaccine is durable. This is something to be shouting out from the rooftops about, because we can save lives. This is the reality of it. And we've got 84 countries around the world with the same set of results. How often does that happen? We have 270 million people who've received the vaccine. We have an abundance of information showing us that we need to vaccinate children. So let's talk more about evidence. The first thing I can tell you is that as a human, you're not very good at handling the HPV virus. In fact, if you get it tomorrow and then get rid of it maybe in a year's time, if you're then infected by the same subtype, you're back where you started. So as humans, we're not very good from an immune perspective at dealing with this virus. In terms of seroprevalence, the best time to vaccinate is when you're young. Okay, so pre-sexual age is the best time to vaccinate. It's also when you get a fantastic immune response. Now, if we look at numbers, this is from 2012, published in 2017, of worldwide cases of HPV cancer. If we cover 16 and 18, we cover about 72% of HPV-related cancers. If we cover these 9 ones, we cover nearly 90%. So that's the reason why we have now a Gardasil 9 vaccine. Now, you may remember I said at the start that there were 19 types of HPV oncogenic strains. Will there be another next generation vaccine? I hope so. Okay, but we have a lot of cross-reactivity as well protecting us. And so this is the very real benefits of getting this vaccine, all these disease processes. So let's see what kind of effect do we have. So this is from England, just published, and you can see this dramatic prevalence of HPV 16-18 in sexually active 16 to 18-year-old females who are offered vaccination at age 12 to 13 have been less than 2% compared to 15% prior to vaccination. What about in Scotland, where they've had consistently high levels of vaccination? Immunisation at age 12 to 13 years associated with a profound reduction in cervical disease. So CIN, the cervical intraepithelial neoplasia, grade 3 or worse, decreased by 89%. Grade 2 decreased by 88%. They're phenomenal statistics. And let me tell you the best way to treat cancer. Don't get cancer. If you're not getting a dysplastic process, you're not going to get an invasive process. What about in Finland? They've shown not only that drop in dysplasia, but they've also have evidence showing a drop in invasive, the translation from dysplasia to invasive disease, and they have shown both. We see in Australia now where the Minister of Health in Australia said in relation to safety, the jury's not out, the jury is very much in. And you can see the benefits from the many years of vaccination that we have there. From the the World Health Organization, they have noted that countries that have included HPV vaccines in national immunization programs have seen a 50% decrease in the incidence of cervical precancerous lesions among younger women. HPV vaccines are extremely safe. We're now not only talking about a reduction in cancer, we're talking about eliminating cancer, eliminating cervical disease. This was like a whisper 15, 20 years ago that one day we could vaccinate against cancer. Now we can. This is a reality. It is a total disaster if a woman does cervical cancer. A disaster, because we can prevent it, and we have the evidence showing it. And you think to yourself, what kind of reviews did the WHO... we're talking about intensive reviews, 74,000 in the last review in 2017. And they showed no difference in rates of serious side effects between exposed and unexposed to HPV vaccine observed. And these are just some of the many global organizations that have the same set of results. It's not often in science that we get that. We get consistency of results. Does it cause side effects? Of course it causes side effects. Ruber-Dohler tumor calor. What's that? That's an acute inflammatory process. So redness, inflammation, pain, heat. So you're going to get it. Mind you, if I injected your arm with salty water, you're going to get an inflammatory reaction as well. But yes, your arm will be sore afterwards. You may also have a headache. You may faint in a very small percentage of people. Therefore, you need to sit down after having the vaccine. You may, if you have an anaphylactic history, get the worst side effect and have an anaphylactic reaction. Again, it's extremely rare though. For every 1 million doses, 3 allergic reactions. In terms of Ireland, adverse events, so if we look at the European Medicines Agency, or indeed the HBRA here in Ireland, one thing you have to realise, a side effect is a known causation related to something. An adverse event, I can report an adverse event on anything that may happen after I take an aspirin, or whatever else. That's an adverse event, and I can publish those, but a side effect is where I show causation. So very definitely side effects of a vaccine, and you get a shot in your arm's going to be sore. For a couple of days, you might get the headache, as I said, as well. If you look at the HPRA in Ireland, and just go to this website, this is a watchdog. Go to their website. Look at how thorough it is. Look at how fast something will be taken off the market if something shows up. And we're here, 1,082 suspected adverse reactions in that time period. And when they go through these, okay, most of these adverse are exactly what we would expect from getting the vaccine. But they also reported these: chronic fatigue, post-viral fatigue, autoimmune disorder. So let's go to the literature. Let's investigate it. We don't have to hide it. We don't have to be scared of this. These are legitimate problems. Let's go and see what does that mean. So this is a study of over 1 million adolescent girls. No evidence to support an autoimmune, neurological, or venous thromboembolic adverse event in relation to the vaccine. Look at some of the other things. This is the European Medicines Agency. Look at chronic regional pain syndrome, postural orthostatic tachycardia syndrome. No evidence to suggest it's related. Look at the entire program in Norway. No evidence to suggest that ME, chronic fatigue syndromes, are associated with the HPV vaccination. So Fergal Malone, myself, and many others, last time I wrote into the Irish Times, I asked 40 oncology colleagues around the country, do you want to join in this letter? Yes, we do. Because we want to stand up and say we fully support the vaccination program for boys and girls. And these are legitimate problems, but are we seeing clustering? Are we seeing a sudden surge? Surely around 83 countries with 270 million doses, we would be seeing a surge in these conditions. Are we? No, we're not. They are legitimate. We see them beforehand. We see them afterwards. So it's not related to vaccination. This is the most recent update from the HPRA. The benefit-risk profile remains positive. We've had no fatalities, which was suggested on some media sources. Let's talk about Japan. So that's where the Japanese stood up and they said enough is enough with this deadly vaccine. That's not what happened. You had very poor government policy is what happened here. A vaccination program was started and it was stopped 2 months later because of media sensation reports about muscle pain, sleep disorders, light and sound sensitivity. And the WHO warned governments against this. Making policy decisions based on weak evidence can cause real harm. What's happened in Japan? In the last 10 years, death from cervical cancer has increased nearly 10%. In 2016 alone, 2,710 women died of cervical cancer. And the mortality rate from 5 other major cancers has declined. So the Japanese Society of OBGYN, the Paediatric Society, the Medical Association, the Association of Medical Science, and 17 other academics have asked the government to do a complete U-turn on this. The Lancet Public Health, unfortunately, when you have access to numbers and figures, we can make very definite estimates in terms of what is the impact of policy. So we can see here that this is just published. The HPV vaccine crisis to date is estimated to result in around 5,000 deaths so far, okay, preventable deaths in Japan. If the crisis continues, up to 11,000 preventable deaths due to cervical cancer will occur over the next 50 years. And if vaccine coverage is not restored in 2020, 700 to 800 deaths will occur over the lifetime of individuals who are 12 years old in 2020 alone. Vaccination is the greatest invention in medical history. There is no question about that, and hopefully you will agree after the lectures this evening. If I was to ask, how do you die of smallpox, you wouldn't know, but that's the reality of it. And also, we can see here the implications, the lifelong disability implications of polio. But ladies and gentlemen, science is just another voice in the room. I can just tell my truth, based on nothing, and like it or lump it, as we've seen some very senior politicians have done. Now you simply declare your own truth. We pay more attention to numerators, such as 16 adverse events, than we do denominators, such as per million vaccine doses. And we have these sort of images. Wake up, America. We have the sickest children of the world, Vaccines equals trading mild illnesses for chronic diseases. It shows such a lack of insight, such a lack of understanding, because the disease processes we're not familiar with because of vaccination. Measles, tragedy kills 35 across unit. Measles outbreak reaches 76. You have measles because daddy reads bullshit on the internet. Juniper Rosso was, her child had autism and she was vehemently anti-vaccination. And what did she do? She took upon herself to read, to educate, to learn. And she did a total U-turn. At one time, there was no question in her mind, vaccinations were a conspiracy, the beast of modern medicine. I didn't think about the possibility that I was putting anyone else in danger, but now I know that I was. And that's the reality of it. When people tell their own truth, as opposed to evidence that we have from around the world, we are putting people in danger. I was always struck by Emma McMahon, in particular that night in the Late Late Show when she said, talk is cheap. This woman didn't deserve to die of metastatic cervical cancer. The busy lady, mother, she had better things to do than dying of cancer. But she's dead. And so is this beautiful young lady. So, HV is a pandemic. These vaccines are proven safety, they're effective, and we need to protect children going forward. Thank you very much.
Thank you very much to Professor Paul O'Neill for that very powerful presentation, and I think you will all agree that the standard of presenting tonight is extremely impressive. And my sincere thanks to Professor Sam McConkey, Professor Karina Butler and Professor Paul O'Neill. Thank you.